Before we start, I would just like to recognize that if we were all at McMaster, the traditional PFD event, we would be on the territory of the Haudenosaunee and Anishinaabe nations. And this territory is covered by the Upper Canada Treaties within the lands protected by the Dish with One Spoon Wampum Agreement. And we're directly adjacent to the Haldimand Treaty territory. And I would also like to acknowledge the other First Nation territories that many of you are on at the moment. So the topic today is teaching and supervising junior learners in virtual patient care settings. I'm your facilitator. Dr. Teresa Chan is the, I don't know your title, Teresa, I'm sorry, head of PFD.
For program for faculty.
Thank you. And, you know, organizer extraordinaire. Teresa's just so adept at helping to break this all down for those of us that sometimes feel a little intimidated by it and making it all happen. So thank you, Teresa. The objectives today are to give you some information that you can incorporate into having best practices in virtual care supervision in your own environments. And I recognize many of your names because you're actively involved with our UG and PG learners for a long time. And I'm sure that this pivot into teaching virtually is daunting. I'm grateful as an intensivist that I don't have to do virtual care. Yeah, imagine that in the ICU. But I have had to have a lot of virtual family conversations and difficult virtual family conversations. And so I have paid keen attention to some of these practices because even though I don't need them directly with my patients, I need them with my patients' families. So learn about considerations for counseling clients and their families via virtual care. So no matter what we do in medicine, that likely has come up and will come up. Also to highlight important considerations in communication with particularly junior learners and patients related to virtual care encounters. So how do you prepare your patient to deal with a junior learner in virtual care? How do you prepare yourself, and how do you communicate with both of them? So our speakers today, I believe in order, is that correct, Teresa?
Yes, I believe so.
Okay, first we have Dr. Keena Bracken from Family Medicine. Then we have Becky MacArthur from Speech and Language Pathology, Dr. David Fahmy from Allergy and Immunology, Dr. Heather Waters in Family Medicine, and Dr. Maria Taboni in Internal Medicine. And each of the speakers will also give you a little bit of the background and why they're here today. And please don't forget to consult the website, which also gives you a more comprehensive bio of each of our speakers. And I really, again, want to thank them for the time and effort they've put into this because sometimes it's hard to get folks to think about, you know, the spectrum of learners across the Faculty of Health Sciences. And many of us in our practices actually encounter nursing learners, physio learners. The other day I was working with a spiritual care intern. So, you know, I think we need to be comprehensive when we think about the needs of learners and think not just about the spectrum of learners from the Faculty of Health Sciences that we encounter, but also the spectrum of learners right from a very early clinical clerk all the way to a very senior resident. And today we're talking about those clinical clerks and junior residents in this talk and people that are at the equivalent level. So yeah. I will stop there and hand it on over.
Excellent. So one amendment I was going to make is that we will actually be inviting Becky and Heather to co-present together. So they're going to go right before David there. And we're going to put Kenya now on the spotlight, and she can share her slides as needed.
Thanks, everybody. So I'm Keena Bracken, and I am the undergrad director and clerkship director for Family Medicine. And I also am the, and I always forget the name of this, clerkship longitudinal experiences, I think that's right, or something like that anyway, Jill. So at the end of the day, this is a topic that became very important for me to quickly gain a little traction on, and trying to figure out the best way of approaching family medicine clerkship in a new world, and the new world that we've all been rather dramatically thrust into. So it became a question of how do we actually manage this, because most of family medicine clerkship, if not most of what we try and do, is achieved in a preceptor's office when you're actually working with students. And typically that's involved an enormous amount of inpatient direct patient care, or in-person direct patient care. So this was a huge change. So here we are talking about virtual supervision, virtual care, and what are we actually talking about? So definitions are usually in order. So this one, it's really a broad term, something that encompasses all the way that healthcare providers can possibly interact with their patients remotely. So that could be a variety of different modalities, including live video, audio, instant messaging, And sometimes the definitions become a little bit more challenging when you think about, is there a difference between virtual care? Is there a difference between telemedicine? Is there a difference between telehealth? And I'm going to put it to you that it really doesn't matter so much. The semantics perhaps are a little bit different, and that telemedicine really talks about also the delivery of technologies. And you're probably aware that there are some remote technologies that through various health-related apps, people have started to communicate remotely with their patients. This could include, for instance, oximetry. It could include various other cardiac modalities, blood pressure monitoring, sometimes direct blood sugar capabilities back and forth to preceptors and clinicians. So really, it's the whole spectrum of what we're talking about. And we have to start to think about what parts of virtual care can we deliver the best, what parts of virtual care may be a little bit more challenging, and not to forget that there are particular nuances of virtual care that we need to be aware of when we don't have that patient in front of us to potentially give us cues that may make reading them and reading their situation a little bit easier. So I think it's fair to say that all of us know exactly what or have heard the term virtual care many times since March 13th, which is the day I came back from Hawaii and went into quarantine. So it's rather indelibly imprinted on my mind, and some of you may have other dates, but all around that particular time in March. So this article you may have seen in CBC May 18th, 2020, which really was talking about how COVID has pushed healthcare in the virtual world. I think all of us can agree that that is definitely the case. We're going to talk a little bit more about how this technology existed prior to COVID-19, but certainly since this has happened to us and happened to everybody that we know in our entire world, really, we have gone light years forward in something that probably would have taken many years to get to the stage that we are at now. Interestingly, back in early January, the Canadian Medical Association had a meeting, and they were talking about starting a task force because they recognized that virtual care had the potential to increase access not just to primary health care, but also to specialist care for Canadians. And we've been doing this for a variety of different countries and a variety of different places in rural and remote communities for some time. So while we had the technology and the ability to deliver that type of virtual care, there were a lot of barriers to its widespread adoption. And many of them will be familiar to most of you, including payment models, licensure and quality standards. And I've highlighted that last piece, which is education and training, because like most of us, we've been thrust into an environment that we didn't know very much about and had very minimal training, if any, on how to actually deliver this type of care. So it's a work in progress and something that we all have to be mindful about as well as we move forward. So my point here is that this was on the table in January of 2020 before any of us realized how much our worlds perhaps would change with the results of the pandemic. I mentioned before, there's certainly been experiential practice with virtual care prior to COVID in the United States, particularly in Scotland, as well as rural and remote areas of Australia, the UK. As mentioned, the US, particularly Minnesota, and the University of Minnesota has done quite a bit in this regard in the past, and certainly in their more remote regions of Canada. We've been accustomed to having telemedicine, as we used to call it, a little bit more there, where you have patients in a remote setting that don't have access to especially to a specialist, and then their care is provided via remote access. So we know that it was certainly possible to do it. We didn't have a lot of experience in terms of monitoring or supervising junior learners, however. In Australia, they had been doing a little bit of this with more like their junior house officers. So these would be sort of the equivalent of what we used to have as interns or perhaps R1s who are working in more rural settings and don't have a preceptor that's actually with them. So they would often record their video encounters with patients and send it back to the preceptor for feedback that way. So there is some precedent prior to COVID that this in fact was doable, although not a lot of experience in doing it in terms of the more junior learners, as I've mentioned. And I had never heard of this, but medical virtualism was a thing. So it was a thing even pre-COVID. So I've just highlighted 4 articles that I managed to find in my sort of review of what we knew about virtual healthcare prior to COVID and what's happened afterwards. So you can see that these articles were published as early as 2015 and then up to about 2018, 2019. So these articles have a gamut of things. So some of them talk more specifically about the technologies that you can deliver remotely to patients. Some of them talk a little bit more about the like that last one, incorporating a new technology while doing no harm. So some of the more difficult nuances about interacting with patients over technology and how you may lose some of that ability and perhaps some of the empathy that we strive very hard and is an integral part of what we do as healthcare providers. So a number of articles were around to talk about how we actually could do this better way before we ever knew that something like COVID-19 would hit us. And then, as we all are probably aware from reading various medical education journals, if nothing else, a variety of organizations were very quick off the mark, and we've seen many journals exclusively donated or devoted rather to publications related to how schools in general have managed the pandemic response and what they've had to do to change their medical education delivery systems. So a couple that I highlighted that were quick off the mark. The first is a British group, which was remote assessment in primary care. So this was a GP practice setting and published in the British Medical Journal early in, I think it was actually in April in 2020. And their experience led to a slide that I will show you in a little while, but certainly very quickly describing how even junior learners could actually see patients and have supervisors that weren't necessarily in the same place. The University of California at San Francisco, mainly through Kaiser Permanente, is the second group, and that link there takes you to a huge resource area full of what they managed to accomplish with a group of longitudinal clerkship students. The University of California at San Francisco and Kaiser, if you haven't been there before, and I had the privilege of doing this a few years ago on sabbatical, have a number of different longitudinal integrated clerkships set up. So they're accustomed to seeing a panel of patients. So even while the universities pulled students out of hospital settings, these particular students continue to see their panel patients remotely with their preceptors also remotely. So I really used a lot of material from them and attended a couple of webinars that they put out very early on in the pandemic to give me some more ideas as to what we could potentially do in Hamilton. And the last one, humanism and telemedicine, I think I wanted to highlight because this really talks about what the quiet sort of empathy and the skill set that you need to communicate with effectively, and the communication skills are really highlighted in a remote virtual-based setting. So this is the publication that came from the British resource that I just mentioned. So why are we even bothering to think about virtual care in this context? Is it good for everything? When should we be choosing it? Why should we be doing it? Some of those are obvious, I think, as in it can help with managing isolation or social distancing, which was why isolation was always an issue for some countries and some provinces and other remote settings in the world. The decision to choose it is shared between you and the patient. I think that's important because there certainly are patients that are not keen on doing this type of interaction. They may not have the technology, they may not have the Wi-Fi access or a secure Wi-Fi source. They may not feel comfortable with the technology. All of these things need to be taken into consideration. I think the other piece that we think about often but don't necessarily state is what the nature of the encounter is. So we hear all the time emergent visits are not appropriate for virtual based care, and we want to make sure that we're not missing diagnoses that require an inpatient person assessment. The calls are safe and secure, the PIPA modality, and we get into that, the Personal Health Information Protection Act. That's something that we obviously need to be very compliant with. So we'll talk a little bit more about that later, and I'll point you to a resource if you're interested in the e-module that I developed earlier. But I'll tell you about that in a second as well. But it is important to make sure that you're communicating under a safe and secure modality. And then I think this point, it saves patients stress, time, and travel expenses. That's something that moving forward, many patients enjoy. The fact that they don't have to pay for parking, they aren't worried about physically removing themselves from their homes in times when it may be very stressful and actually not a great idea for them to do so for a variety of reasons. So the e-module I developed back in the end of May was really trying to pull together what I managed to source from my quick scoping literature review. And within MacHealth, there's a number of various excellent resources that many people have provided. This was the resource list as part of the e-module that I developed, Supervising Learners and Virtual Care. So it really does talk about both undergraduate as well as postgraduate learners, but it might be something that you want to look at on your own time if you haven't already, which gives you a much more specific breakdown of all of the essential components to providing good virtual care. And then there's another one, which I'm going to, hopefully isn't going to start playing. This was heavily borrowed from the Kaiser Permanente University of California, San Francisco series that I told you I participated in over internet. So this is really the synopsis of what they try and do. So if you look at the e-module later that I developed, you'll see that it really does lay the groundwork, which is number one, which is circled, which is the preparation piece, both from the student perspective as well as the patient perspective that's critical to a successful encounter. Then two is the actual sitting by the fire, which is the student-patient encounter. And then the third is the synopsis with the coming together of the student, the patient, and the preceptor all together. So I won't go into any more details. You can look at the module if you're interested in that, but it really does talk about the importance of engaging everybody in that triad. So preceptor, patient, and student, setting expectations early, and then making sure that you have a debrief time to go over things, both from the preceptor student perspective as well as the patient student preceptor triad. So I think I'm going to end there. Thank you.